Good morning, everyone. Again, welcome to Masterclass Season 3. You are aware that we had a Masterclass Series 1 and Masterclass Series 2. One we had in 2020 when we had the COVID times, and then we started the Masterclass, and there was a huge success of Masterclass Season 1 when we had 32 lectures on various GI topics, and they are still very popular. Then last year we had a Masterclass Season 2, and when we talked about 12 cases of clinical case discussion, that also was quite appreciated by many people. Now, after that, we thought that why not we discuss about GI pathology and GI radiology, and therefore we decided that we should have a third series of masterclass that is on GI pathology and GI radiology, and this is the first first session on the series 3 of ISC masterclass. In this series, we'll focus 4 lectures or four discussions on GI pathologies, and then 4 on GI radiology. In pathology, first we'll talk about liver pathology, then small intestine, large intestine, and esophagus and stomach together as a 4th one, and then we go to GI radiology. So again, welcome to Masterclass, and for this Masterclass, we have one of the most astounding professor of pathology and our mentor, I would say, Dr. Siddharth Datta Gupta. Siddharth Datta Gupta had joined AIIMS New Delhi as a student in 1981, and he has a very illustrious career. And he, in 2020, he superannuated as a professor of pathology from AIIMS New Delhi. He also served as the Dean of Examination of AIIMS, and he led to a number of positive changes in the exam section in AIIMS. Dr. Datta Gupta is a wonderful teacher, and the way he describes pathology and the way he teaches with his own creativity is fantastic. And he kindly agreed to talk to all of us on the topic of the liver pathology. Thank you, Dr. Datta Gupta, and welcome to ISC Masterclass. And to moderate and chair this session, we have a Dr. C.E. Epan, like a very dear friend, and very one of the top hepatologists in our country. He's head of hepatology at CMC Vellore, and is a great teacher. Thank you, Dr. Epan, for accepting to be moderator for this session. We have Dr. Mahesh Goenka. I think all of you know Dr. Goenka. Mahesh Goenka is now president of our society, and again is one of the top endoscopists known globally, and again in our country. He is one of the best teachers I have ever met, and now I hand over to Dr. Goenka to address you and introduce Masterclass.
Thank you, Govind, and good morning, everybody. It's my pleasure as the president of Indian Society of Gastroenterology to be starting and welcoming all of you for this third session of Masterclass ISG. I must say that the first 2 sessions, I had the opportunity of attending a majority of them, and they were really very, very educational. And I think those who have attended those sessions will understand the value of these sessions. I must say that Indian Society of Gastroenterology is one of the rare societies which are always looking at opportunities to teach our youngsters, postgraduate students, DM and DNB students. We have various platforms. YCP is one platform, GYM is another platform, and we are starting with another platform very soon for the second year DN DMB students, which will be how the guidelines and the method of dealing with various diseases. That will be the first time we will be starting. So I'm very happy that today we are starting with liver pathology, and you have 2 stalwarts in liver. One who is possibly one of the best clinicians, Dr. Epan, in this country and around, and also Professor Datta Gupta, as Govind rightly said, is pioneer pathologist. We have all learned from him, even if we have not been his students, during his deliberations in conferences and workshops. So I look forward to this and subsequent sessions of Masterclass. From the students' perspective, I'll tell you that please inform rest of your colleagues as well. This is a golden opportunity to educate yourself on these 2 areas which we usually don't discuss much, at least in all the colleges. radiology and pathology, which are so integral part of our training as well as our clinical practice. So with that brief introduction, I'll pass on to Dr. Deepan to carry us through this session.
Just one more second, that there's a chat box. So if you have any question, please do write on the chat box. Dr. Epan now.
Thank you. I would first of all like to appreciate the strong leadership and vision provided by the ISG office bearers, Dr. Goenka and Dr. Govind Makari as President and Secretary of the Society, of taking on academics and teaching as one passion for the country. And this is bound to have effects and will impact the care delivered to patients across the country. So today's topic is liver biopsy, and I must say I'm looking forward to learning from Dr. Dattagupta's vast experience in the next hour or so, hour and two, to listen to what he will teach us. Liver biopsy is not taken lightly as a procedure, and because of the seriousness of the procedure per se, the patient and family also views it a little differently and apprehensively await the results of the biopsy. As with all biopsy, interpretation of the result and conveying it to the patient in an understandable manner is the responsibility of the clinician, not the pathologist. So it's very important that the clinician understands what the pathologist is talking about and then conveys the impression of the findings of the biopsy to the patient appropriately. It's equally important to have open and frank communication between the clinician and pathologist to help improve the findings and the analysis of this procedure. So with that brief two-line introduction, I would now invite Dr. Dattagupta to give his talk. Sir.
Thank you very much, Dr. Ethan, for those kind words and introduction. And I'm at the outset, I must thank Dr. Goenka, Dr. Makaria, and the entire ISG. I've attended several ISG conferences and forum. I've been closely associated with gastroenterologists. And during my period of work, invariably my evening tea would be with one of them in the institute. So that's how closely we used to work. And I, as an outsider, I can vouch for one thing. ISG is one organization in our country that has always worked for educating all their members and others in gastroenterology. There's hardly any other organization other than maybe the Indian Academy of Pediatrics, which do such wonderful job in educating this one. And this is absolutely wonderful. I feel honored and privileged to be part of today's deliberation. So with this, I think I'll start. Can I share my screen?
Yes, please.
Thank you once again.
Dattagupta, if you can increase the volume, if you have a
Okay. I'll increase. Now is it okay?
Better.
Yeah. Yeah. Okay. Can you see my screen? Yeah. Okay. Well, now we come to I'll introduce mainly to how we interpret liver biopsies. It's not possible to do the entire thing in one day, but at least it will give you an overview of the interpretation. Yeah. Okay. The liver is a wonderful organ. And if you see in your training of gastroenterology, hepatology forms a part. Liver diseases, unfortunately, are a common cause of morbidity and mortality in this country, and especially because we have high rates of HBV and HCV. And this is something that all of you are well aware because of our population. In fact, 1% rate of any illness, incidence or prevalence, if you multiply by the billions, it's almost equal to any European country. So, always we deal with large volumes of diseases. Even if it's 0.1%, it may be like one of the small entire population of a country in Europe or in some other place. Unfortunately, for liver diseases, there are very few centers that are dedicated, except now gradually because of transplants, it's been increasing. The main reason is most liver diseases are difficult. You have acute liver failure, chronic hepatitis, cirrhosis. They are almost very difficult to treat, often medically. Therefore, it appears less rewarding. You require a huge teamwork. The pathologists, radiologists, the gastroenterologists, and other supporting departments. And there are very few histopathologists. We are a dying tribe, actually, who work with hepatologists. And even trainees apparently are not interested because endoscopy is perhaps more lucrative. So luminal gastroenterology is better. So with this, and there's a fear of liver biopsy, both in the clinician, often more than what's in the patient, as Dr. Epan rightly pointed out. There are many things associated with this. And there's very limited specialization in histopathology of the liver. So it's very important that you know why the liver biopsy is necessary, how it's performed, and what does it convey. So we'll go to the indications, technique, interpretation. Liver biopsies are mainly used for diagnosis of certain liver diseases, and more so nowadays for systemic disease, because a major load of liver biopsies was for chronic hepatitis, and nowadays you have excellent non-invasive tests, and you hardly require a biopsy except for staging and grading. So some of the indications have become less over the years, but it's definitely helpful in monitoring efficacy of therapy for other diseases, especially like alcoholic, iron, copper overload. And of course, you require tissue for special studies and research. And of course, you do research only when it's ethically approved. The majority of the biopsies are done nowadays for cancers, malignancies, and some chronic liver diseases. It's very few indications are remaining for acute liver disease. For some of the metabolic liver disease, you still have to do, and in certain specific post-transplant settings. So some of the common diseases that we do for are for NASH, PBC, Wilson's disease, certain PUOs, like you find a CMV or a fungal infection, a tuberculosis, and of course some other diseases. We'll come to that later. Liver biopsies also can add to, or at least narrow down, the clinical diagnosis. That's very important. You have 4 or 5 clinical diagnoses depending on the lab results as well as your clinical findings. And then you do a liver biopsy. If you can't pinpoint a diagnosis, at least with the help of ancillary tests, you can narrow it down to 1 or 2, and then it at least helps in management of the patient. In children, of course, the indications are a bit different. For example, it's used in various cases of neonatal cholestasis, in certain cases of cryptogenic cirrhosis, especially due to metabolic liver diseases. You can stage chronic hepatitis like in adults, and etiology of duct involvement in certain cases, drug-induced liver disease as in the adults, and masses, and so on and so forth. So if you come to the indications presently, it's for uncertain clinical diagnosis, at least narrowing down differential diagnosis. You can procure the tissue for further analysis, like enzymes, chemicals, microbiological, molecular biology, for grading and staging of various liver diseases, especially chronic hepatitis and NASH, for follow-up assessment once you have graded and staged them, And if there's no other alternative method left, your imaging is unhelpful, your non-invasive techniques are unhelpful, then many a time you resort to a liver biopsy. And of course, to confirm the results of other tests and research. So the clinic, you have to always remember in adults and in children, some of the clinical scenarios are different, especially in children where you have a sizable number of genetic or developmental diseases. And of course, there are many diseases which lacks evidence-based guidelines in children, and that is why, unlike in adults, they cannot proceed without a liver biopsy. The problems with liver biopsy are there's a high risk, especially of hemorrhage. Then in children, you sometimes resort to anesthesia, and there are difficulties in getting tissues. So the complications are similar to what you see in adults. Now, the biliary system is unique in which it not only has a venous and arterial system, it also has a biliary system attached to it. And then you could have obstructions, and the biliary system passes through the pancreas, and therefore pancreatic diseases also can affect this. So therefore, in the liver, you have two venous systems, a portal and a hepatic venous system. There's a systemic one. Then you have an arterial system and a biliary system, all mingling in this wonderful organ which has thousands of metabolic functions to do. So therefore, the problems are plenty. And unfortunately, both clinically and histologically, the liver reacts in a similar way. For example, hundreds of diseases can cause cholestasis clinically. There's no way to distinguish many of them. At birth, you may say this is obstructive, non-obstructive. Many of them, most of them cause jaundice. There's no way to distinguish clinically what it is. Similarly, histologically, many of these changes are almost alike, whatever may be the etiology. Therefore, a lot of it depends on clinico-pathological correlation, which Dr. Eapen rightly pointed out. So this is the liver. Most of the biopsies are performed in the right lobe. Therefore, if there is patchy disease affecting predominantly the left lobe and not the right lobe, you may miss it. It happens, especially in primary sclerosing cholangitis affecting one portion of the liver more than the others. Okay. I'll not go into the details. It's now a day procedure in most institutions, but it will do. So you have needle aspiration, which could be blind or image guided, or it could be through endoscopic or surgical punch biopsies when you open the biopsy. Now, what are the problems in liver biopsies? This is one of the reasons why they are not done that often, but it's been found that bleeding can be anywhere between 1 in 2,500 to very rare, 1 in 10,000 or even less. And minor and major complications are actually less than 10%, and major complications are less than 1% in most cases. And certain diseases like amyloidosis and other things where there's a lot of deposit of the amyloid, it can result in an increased propensity to bleeding. And of course, if you if you poke your needle into a hemangioma or some other, say it's going to bleed much more. The other complications are pneumothorax, hemothorax, perforation of any other organ, and so on and so forth. Most of the fatal hemorrhages are associated with malignancies, and therefore malignant liver diseases show a greater propensity to risks compared to the non-malignant. And what's important is that it's been found that all this to a certain extent depends on the operator and the training of the operator. If an operator has performed more than 100 liver biopsies, the chances of complications are much lesser than those who have performed fewer um, liver biopsies. And therefore, during the period of your training, if first supervised and then of course unsupervised, if you have the opportunity to do a liver biopsy, please do it so that it helps you later in practice. And a large study recorded fewer complications with the true cut needle than with the Mengele needle. Okay, so and a very recent meta-analysis shows the overall bleeding rate was less than 2%. They have studied numerous studies, and the risk factors were older patients or very young patients, comorbidities, especially with coagulation diseases, and if the INR was raised. So anyway, so these are things you learn better. The other problem with liver biopsies is needle track seedlings, especially when there is hepatocellular carcinoma. Therefore, hepatocellular carcinomas actually now it's been refined so much that in a cirrhotic with raised AFP, I mean, and dual or triple phase CT, you can make a diagnosis. You don't require a liver biopsy. This is one of the malignant diseases where you don't require a tissue diagnosis to start therapy. Perhaps the other one would be a post-gestational choriocarcinoma. So that's one of the peculiarity of liver diseases. Malignancy where you actually need not, you can start the therapy in certain clinicals. But overall, in experienced hands, the needle biopsy of the liver, I know in our institution, all of them are well versed and it's very safe. In fact, it is safer than perhaps crossing the road in Delhi. So the chances of you're getting knocked off will be much more than you're dying of a liver biopsy. So anyway, you have to take care and then do it. There are various needles that you use. Your own institution will have certain needles that they prefer. Your pathologist also will be well versed to report on those biopsies. So stick to it and get trained in that. There's nothing that this needle is better than that and so on and so forth. But in general, for cirrhosis, this cutting type of needles are better than the suction type of the needles, right? And the other thing is the size of the needle is very important. Don't take small biopsies, For certain things, it's very important that you have an adequate length of biopsy. It's now known that at least if you have a 2 centimeter length of tissue, that's adequate for staging and grading, especially in chronic hepatitis, because changes are patchy. You can undergrade or understage these, and it will not relate very well to your clinical findings. And therefore, if you use a 16 or 18 gauge needle, it is always preferable. And the number of passes, if you take a biopsy and it's say 1 centimeter, then you can have another pass. If it is 2 or 3 centimeters, you need not do, the tissue will be sufficient. A maximum of 3 passes, because beyond that, generally the risk of complication increases. For example, if you have an inadequate biopsy like this or this, the findings are difficult to interpret. So the current recommendation is 20 millimeter, but the ASLD, the American group suggests a 3 centimeter. So the British group suggests a 2 centimeter length. So let's keep at least 2 centimeter minimum with 16 or 18 gauge. We'll come to that. But please ensure it's not very thin. Sometimes the radiologists use the Chiba needle and others which are very thin and not good for interpretation. But it's not necessary that for all diseases you require a 2 or 3 centimeter. This was a biopsy that we received, a small bit here and a skin here. So a new resident must have done it and pulled out a bit of skin and this. And this was sufficient. It showed amyloidosis. This is the Congo red, and this is the apple green birefringence, and this is thioflavin T, which gives a fluorescence with amyloid. So this, in fact, it was 2 or 3 millimeters in size. This was more than enough to make a diagnosis. But generally, for most indications, you require a good core, or at least 4 to 5 portal tracts. Now, the length of biopsy, especially when you're doing grading and staging, because viral hepatitis, chronic hepatitis is one of those diseases where you do liver biopsies. NASH is another. And of course, post-transplant acute rejection, you do a rejection activity index. So all those, it's better to have a fairly adequate length of biopsy. Okay. And reducing the length actually led to more of grading which is milder than it's more severe, So therefore, smaller biopsy will give you a milder grade, and that's why it affects the therapy. Same thing happens to staging. You can miss cirrhosis and other things. And almost in smaller biopsies, up to 20%, you may say it's not cirrhosis when there is cirrhosis. Okay, so
Datta Gupta, just one second.
Yeah.
So I think I just noticed that the screen is not visible to the participants. Is it so? Is it so, Prashant?
It's visible, sir. Visible.
Okay, so one of the colleagues I told that is not visible. So Datta Gupta, your volume, can you increase the volume slightly more if it's or maximum?
It's maximum.
Perfect.
Okay.
Perfect.
Thank you. Right. Now, the other.
Just one second, sir. Prasanjit, are you able to see the screen now? All right, sir.
Dr. Govind, is this volume better or the earlier one?
No, this is almost similar, sir. This is almost similar.
Almost similar?
Yes, sir.
Sir, your volume is okay, sir.
All right.
Okay. Okay. The other thing is, what you should not do is, suppose you have 3 cores, don't send them to 3 labs. That is something that many people do. It's better you send them all to one place and then take the blocks, and then you can take a second, third, fourth, fifth opinion. For example, this 3 cores, 1 core showed cirrhosis and 2 cores showed hepatocellular carcinoma. So now in this case, if this went to one lab, this core or this core, and this went to another lab, you can imagine this confusion in the mind of the gastroenterologist and of the patient and everybody else. So therefore, please send all of them to one place, take the block, and then if you want to have second, third, fourth opinion, you please do it. And the other thing is, for example, this is primary sclerosing in cases of primary sclerosing cholangitis. This is the biopsy. We do it in the right lobe. Suppose it's a small duct PSC and your needle goes through it. Wonderful. You'll get all the changes that are necessary to make the diagnosis. Now, suppose the larger ducts are affected and the biopsy goes through one area where the smaller ducts are not affected. So you will get the features of a bile duct obstruction on biopsy. You will not get the typical changes of PSC because the obstruction is somewhere distal to it, somewhere here, not here. And in the third one, suppose it affects mainly the left lobe and these ducts, and you're taking a biopsy here. If the bile flow from these ducts are normal, you will not get any changes at all. Therefore, in certain diseases, the liver biopsy cannot be the gold standard. And in fact, for PSC, that's why imaging is the gold standard. So these are some of the limitations that you can have in a liver biopsy. So the errors are unavoidable when the disease is not diffuse, like in chronic hepatitis. The next thing is, you must remember, needle biopsy samples about 1/50,000th of the liver. You may say, "Oh, what use is it then?" It is useful because geologists sample at least 1/1,000,000th of the soil of your earth and they tell you what's deep inside, whether you find petrol or not. So similarly, liver, although it samples a bit, it doesn't mean that it won't give you any information. So it gives you. The serial sections are important. You study many sections. And for focal lesions, you take guided biopsy. The other thing is, if the biopsy is very superficial, normally from the capsule downwards, you get certain septa. So you tend to misdiagnose cirrhosis in those cases. We'll come to that a little later. So this is you get needle biopsies, wedge biopsies. And because I told you the subcapsular region normally has septa going down, which you can mistake for cirrhosis, the wedge biopsies should always be very deep. It should be like a cup rather than like a saucer. And this is very important because our GI surgeons usually take a wedge biopsy along with the deeper needle biopsy when they do a shunt surgery to rule out, to confirm that it's not cirrhosis. And that's why a needle biopsy is looked at and the wedge biopsy is deep enough. So you see, this is the subcapsular region. We have a thick capsule. Normally just below the capsule, there's a lot of chronic inflammation. This is normal. Why it happens, people do not know. And therefore, if your needle passes through this, you can misdiagnose this as chronic hepatitis with some fibrosis. And look at these septa, how they go in. And therefore, a needle biopsy going through this, you may say there's a lot of fibrosis. Whereas in the deeper area, there's no fibrosis. Therefore, a needle biopsy or a wedge biopsy should be at least 4 millimeters or more deep into the liver tissue, right? So this is very important. The other technical aspect, of course, folded and other sections that the technicians in the lab should be aware of. Do not try to squeeze the biopsy with forceps when you're trying to put it into a bottle. So these are artifacts that one has to remember. The liver biopsies are processed in paraffin. Generally, frozen sections are used for certain specific indications. And when you put it in paraffin, it shrinks in size by a few millimeters. That's a little longer length would be helpful. And these are the multiple cores that you see. You study serial sections. The thickness of the biopsy depends on what the pathologist is happy about. This is a little thicker one, this is a thinner one, and both are equally fine. Generally 5 microns in thickness. And please work with your clinician, right? The laboratory and ward are the two sides of the same coin, and it's very, very important. You must talk to them rather than exchanging notes of all kinds, of course, between them. It's useful in about 80% of the cases, but in some cases, in about 20%, liver biopsies may not be very helpful. Now, if you come to the normal liver, the liver actually diagrammatically is shown as hexagons. It's not hexagon. It's almost a continuous tree. And it's peppered with certain areas where you have the term branches of tributaries of the terminal hepatic venule and what is called the portal tract or portal triad, right? So we'll go into this. And you have cords of hepatocytes in adults with the sinusoids in between. And it's called a sinusoid because unlike a capillary, it doesn't have a continuous basement membrane. So there is a free flow of fluid from what is in the bloodstream into the space in between the hepatocytes and the endothelial or the Kupffer cells. It's called the space of Dissect, which you cannot see generally in routine section. And then you have the hepatocyte, right? So on the other side, between two hepatocytes, they actually cup together to to form a canaliculus. There is no lining as such here. There are two hepatocytes. They form the bile canaliculus. In fact, it is very peculiar. It's almost like the kidney, where you have a countercurrent mechanism. Here, of course, you have the hepatocytes in between. The sinusoidal blood flows from the portal tract towards the terminal hepatic venule. The bile flows from in the other direction towards the biliary tree in the portal tract. So it's almost opposite direction this flow occurs. Okay? So this is almost like what you see in the kidney. Now this is a normal liver. See, when you see under low power, you will find these areas where there is a little lightly stained fibrous tissue also, and these are the hepatocytes, and these areas where there are just punched out holes without this fibrous tissue. Now, this is called these are the tributaries of the terminal. These are the terminal hepatic venules which drain into the hepatic vein, and this is what is called the portal tract here. And here, if you see in the low power, the largest area which is completely open will belong to the portal veins. So this brings blood from the portal veins. They're thin walled and large. And then you'll find these smaller structures, which are the arterioles and the bile ducts, right? And therefore, you have this actually repeats all over the liver. You have this portal tract, you have the terminal hepatic venule. You have a portal tract, terminal hepatic venule. This will be near the terminal hepatic venule, partly seen, and this will be the portal tract. So therefore, and there's no separation between one lobule and the other that you see in this. They are almost continuous. So they are divided into lobules or acini. According to the lobular concept, all the portion of the liver around the terminal hepatic venule is called the centrilobular region, and just along the portal tract, it's called the periportal region. And this is the mid portion of the lobule. But then there's another person called this Kernian who told that. Another person called Rappaport who gave a concept. It's called a Rappaport's concept. He said, no, the blood flows from here to here. So this is the central portion of the liver. And the blood flows like this in various directions. So actually, you have these berry-like areas supplied by the blood going in one direction. And so he called these as an acinus. One acinus is composed of an area in which the central area is the portal tract and the peripheral area is the terminal hepatic venule. And so these are berry-like areas, rounded areas. This much of blood is supplied first, and then this, and then this. So this area he called as zone 1, this is zone 2, and this is zone 3. In fact, the oxygenation is best here and least here. And because they are like this in circular fashion or berry-like fashion or oval fashion, this also explains the fibrosis that can occur in these watershed areas, and that's why they are almost rounded in cirrhosis. Anyway, this is a concept that he said. The enzymes, etc., in zone 1 a little different from zone 2 and zone 3. Like, for example, phosphorus and other things will be metabolized here, INH will be metabolized here, and so on and so forth. So you see, so these are the three zones: zone 1, zone 2, zone 3. Now, zone 3 roughly corresponds to centrizonal area, zone 1 roughly corresponds to periportal area, and zone 2 roughly corresponds to midzonal area. So in the lobular concept, area around the periportal, around the portal tract is periportal, area around the terminal hepatic venule is centrizonal, and in between is midzonal. In the Rappaport's acinar concept, Area around the portal tract, like a berry, is zone 1. Area around the terminal hepatic venule is zone 3, and this is zone 2. So in your reports, you will generally find people writing zone 1, 2, and 3 rather than periportal, midzonal, and centrizonal. So this is one thing you have to remember. The second thing is, in the portal tract, I told you, there's fibrous tissue, and these are the portal veins which are most dilated. And you'll find an arteriole and bile duct. Embryologically, both of them, these arteriole and bile duct, develop together. And that is why wherever there is an arteriole, next to it, you'll find a bile duct. So it's very near. In fact, you take the diameter of an arteriole and go all round, you're likely to hit a bile duct somewhere there. And the diameter of the arteriole and the bile ductule here will be almost identical. So if you want to find a bile ductule, you have to search for an arteriole. And the larger one, this is the portal. Now here you will find there are the lobules in pigs and swines are separated by fibrous tissue. This does not occur in human beings, and therefore it's very difficult to separate lobules in human beings. The other thing is there is no fibrous tissue separating the portal tract from this parenchyma full of hepatocytes. So, but the last layer of hepatocytes here is called the limiting plate. So this is the boundary between the remaining part of the parenchyma and the portal tract. So this last layer is called the limiting plate. Cells can flow from here to here, especially the inflammatory cells, very easily. And they can destroy the limiting plate when it is called as piecemeal necrosis or interphase hepatitis. So what is the limiting plate? It is the last layer or layer of hepatocyte that separates the portal tract from the remaining parenchyma. Now, if you come to the bile ducts, see, they start with the canals of Herring, which are in between the cells, the hepatocytes at the limiting plate, and then going. You can't see them normally. And then, of course, the bile ducts gradually increase in size. 15 microns is the size of a, say, neutrophil. So from that size, they are the small bile ductules or cholangioles. Then they increase interlobular ducts, which you can see usually very easily, septal ducts, area ducts, and large ducts. Okay, so that's how the biliary duct is seen in the portal tract. They are large. Now, in a portal tract, because of the sectioning, you can see all the three structures: bile ducts, hepatic artery, and portal vein. Because you see all the three, that is why it's called portal triad. But it's not necessary that in every case you'll see all the three structures in all the portal tracts. So if you you may see one of them absent. Usually the portal vein may not be seen. But the important thing of noting this is that in NCPF also you don't see portal veins. Therefore, the clinical findings are very important before you interpret. And just because you don't see in one portal tract, you don't make a diagnosis of NCPF. The hepatic artery may be absent in some, and bile duct may be absent in others. So this is the liver parenchyma, and please note it is nowhere near what is shown in textbooks or what you write, like it's very nicely arranged in the form of parallel cords of cells with the canaliculi here and the sinusoid here. The liver's cords are in the form of a maze. It has to slow down the blood. Only then the Kupffer cells can find out if the RBCs are damaged or not and engulf them, and the exchange between in the space of Disse can occur properly. In an adult, the liver cells are 1 cell thick. You see this here? Their cords are 1 cell thick, and sometimes you can see the canaliculi here. When it is regenerating, or in children below 4 or 5 years, they are 2 cells thick, right? They are 2 cell thick. When they are 2 cell thick, it means it is regenerating, or that you can get in cirrhosis. If it is 3 or more cell thick, then it is abnormal. You get that in malignancy or hepatocellular carcinoma. This is very important. So thicker the cell cord, more the likelihood that it is malignant. Normally, the canaliculi cannot be seen. You don't see bile in the canaliculi. If you find bile visible in the liver, then it is abnormal in a liver biopsy. It is always abnormal. It indicates some form of cholestasis. And bile canaliculi are generally not seen. Bile can be seen in the canaliculi or within the cells. So if you see within the cell, it is called cellular cholestasis. If you see in between the cells in the canalicula, it is called canalicular cholestasis. Now, there are certain specific terms that we use when we see bile. You can call, it is called bilirubinostasis, because bile is made of bile salts and bile pigment. What you see in this green color are the bile pigments. It is bilirubinostasis. The bile salts are toxic. Bile pigment is not toxic. Bile salts are toxic and it causes ballooning, degeneration and necrosis of the liver, and that is called cholate stasis. So if you find this ballooning and other things with this bilirubinostasis, it is mainly because of bile salts which are toxic. It's called cholate stasis. Both the combination of cholate stasis and bilirubinostasis, or which is generally goes under the name of cholestasis, is a manifestation of biliary obstruction due to whatever cause. Now, I talked about canalicular cholestasis. The canals of herrings are generally not seen. This is at the junction of the portal tract and the last layer of hepatocytes. Cholestasis within the canals of herring, if you see, especially like this yellowish bile, is a sign of septicemia. So you can see it. Now here, this is canalicular cholestasis and bile duct proliferation. All this is a manifestation of obstruction. So this is a bile duct proliferation you see with or without cholestasis. Bile duct proliferation may be associated with infiltration by inflammatory cells. So that's another feature of cholestasis, when the bile does not flow. The other feature of cholestasis when bile does not flow are bile infarcts, necrotic areas impregnated by bile, especially in the periportal area. And this is all once again because of bile salts. Okay. And you get bile lakes. Bile lakes are within portal tracts, where the bile, because of obstruction and distension, they get extravasated. All these are signs of obstruction. The other signs of obstruction that you can get are Mallory's hyalin, increase in copper binding protein, because copper is also excreted with the bile, or of copper in the periportal hepatocytes. So this is again, this large portion in the portal area. These are the bile ducts. This is the artery. Please remember that. The other thing, you hardly get inflammatory cells in the portal tract. You can get inflammatory cells normally, few in the portal tract, and in children, you can get extramedullary hemopoiesis. These are normoblasts and megakaryocytes within the sinusoid. This is normal. The space of decay cannot be seen. This is one instance in autopsy, liver, because of autolysis. These cells separated out. These are the sinusoidal cells. These are the hepatocytes, and this is the space of decay. Normally, you don't see it. This is because of autolysis. You can find the sinusoidal cells better when there is malaria, because they swell up with pigments, or when there is hemosiderin, right? Now, this is a liver. You can see this is a portal tract. What is abnormal? In this, there is no portal vein. This is the artery. This is the bile duct. There is no portal vein. In this, You see, artery is there, the portal vein is there, there is no bile duct. So you see, one of them is lost, right? So that's why people have to examine systematically. The other thing is, different things may show the same feature. Here you are finding neutrophils destroying hepatocytes. Now, if you see carefully, when do you get it? You can get it after prolonged surgery. So if there is an abdominal surgery and the surgeon is handling the liver, you get this neutrophils here. The neutrophils can be seen also in alcoholic hepatitis, in cytomegalovirus infection. So if you have a history that there was no CMV or there's no alcoholic hepatitis, but this is a liver biopsy after a prolonged surgery, shunt surgery or liver transplant, and you find neutrophils, then you report it as surgical hepatitis. So this is the importance of history whenever you do a liver biopsy. So that's why a constant communication is necessary between the clinician and other things. So what are the stains that we do? HND, we do usually a diastase pass, reticulin, mesons trichrome. These are for fibrous tissue. And special stain for copper, for iron, again for copper, and for organisms, and then you do immunohistochemistry. So this is a PAS. We do a diastase pass because the liver is rich in glycogen. When you do a PAS stain, a periodic acid shift, it will stain the entire thing. So when you do a diastase pass, it removes the glycogen. This is an alpha-1 antitrypsin deficiency. These are the alpha-1 antitrypsin bodies which are positive here, right? So that's why we do a diastase pass. Diastase pass stain is also done to study lipofuscin. These are Kupffer cells with lipofuscin pigment, and this can be seen when you're recovering from hepatitis. This is a reticulin stain. Reticulin, we see the normal maze-like pattern of hepatocytes. When it becomes parallel, then we worry. It shows that the hepatocytes are becoming parallel, that we see in drawings, and it means there is an alteration in the architecture. You see this, and you can make out cirrhosis better because you can see this fibrous tissue around nodules with the reticulin staining. This is the normal liver. When the reticulin disappears, then you worry. In an HCC, you generally the reticulin is lost. This is a poor man's way of telling that you're dealing with HCC. In an adenomatous nodule, there is a partial loss of reticulin because the sinusoids are not formed well in HCC, so the reticulin gets lost. So this is a cirrhosis, biliary type of cirrhosis, where you can see. Reticulin is helpful in other conditions. This is a case of portal hypertension, looks almost normal. But when you do a reticulin stain, you'll find this. This is a nodular regenerative hyperplasia. This nodule wouldn't have been seen clearly otherwise. The mesons trichrome is not helpful. The mesons trichrome tells you collagen. It helps in identifying cirrhosis. Cirrhosis with rounded nodules is mainly because of hepatitis, post-hepatitis. Cirrhosis with these geographic nodules are because of metabolic liver disease or because of biliary obstruction. Serious red is another stain that we use. This is the Orsin stain. Orsin stain stains elastic tissue normally. It stains these tissues whenever there is cirrhosis. It stains copper binding protein in the periphery. Okay. It also stains hepatitis B surface antigen. So there are several things it stains. But better still, you can do an immunohistochemistry for surface antigen, core antigen. Core antigen stains the nucleus. Surface antigens generally stain the cytoplasm. There are different patterns of staining, right? So this is a 3-year-old girl with congenital hypobilirubinemia and ocular and pulmonary changes. What you're finding are portal tracts with portal veins, arteries, no bile ducts, right? And if you search all of them, there are no bile ducts. This is cytokeratin 19 staining, which shows no bile ducts, right? No bile ducts here. And this is a normal liver. So you are supposed to see bile ducts like this. So the immunohistochemistry has helped. There's a paucity and it's consistent with hepatic changes in allergens because of the ocular and pulmonary changes. Normally, if you find arteries, the bile ducts are seen in 0.8. The ratios bile ducts to the portal tracts are about 0.8. If it is less than 0.5, it is diagnostic for paucity. Between 0.8 and 0.5, it is suspicious for paucity. There are various causes. One is allergens, which is syndromic. Non-syndromic, you can get in alpha antitrypsin deficiency, biliary diseases of long standing, Hodgkin's disease, chronic graft-versus-host disease, and so on and so forth. The other immunohistochemistry, you can do arginase 1 and glycopan 3, which is helpful in identifying HCC. So with this, we'll take a small break and then we'll do few cases. Any questions?
Dr. Epan, will you
Yeah.
come in?
Yeah. Thank you, Dr. Datta Gupta. We'll
Prashant,
give
can
you.
view them, Prashant.
I think you deserve a
Hello?
5-minute break to catch your breath. So,
We'll just
so
do some.
yeah. So we
No.
really enjoyed your talk. I think some questions are coming in. Let me start with 1 or 2 questions from my end.
Yeah.
First is, you've described a series of stains which are done on liver biopsy.
Yeah.
Would you recommend that all biopsies have all stains, or are there any particular set of biopsies which are standard and some more depending on the clinical scenario? How do you go about it?
You see, in a liver biopsy, which we do generally for hepatitis and other things, the mainstay is H&D, that hematoxylate and eosin. Then instead of special stains, we call them usuals. One is diastase sparse, the other is reticulin, and a stain for collagen. You do a Sirius red or Mason's red. So these 4 stains are generally done routinely in all liver biopsies. Then supposing you are suspecting, say, Wilson's disease or anything, then you have to do copper stains. You want to do for hepatitis B surface antigen. Nowadays, if it's HBV, generally we do a immunohistochemistry for S and core antigen. Others we don't do. If it is HCV, we generally don't do any of. So it is HND, diastase sparse, reticulin, and a collagen stain is done in all biopsies. Then the other ones for iron, and you are absolutely right, depending on the clinical. Or after doing this, all of a sudden we find a lot of hemosiderin pigment. Then we would like to do an iron stain for whatever cause there is, and so on. So
Thank you, sir. This is more of a pathology question only, really, but it'll help the clinician. What you just now said, is it a practice of one institute or it is a standard across the world? This approach to staining of the biopsy, what you just now said.
yeah, this is the approach in most all over the world.
Okay.
Even in UK, they used to do this same thing. Most places they do this.
Okay.
So it's one way.
I have a second question for you. Again, I expect it may help the clinician. See, when we do a gastroscopy, there is one method of doing it. Maybe we look at the esophagus first, then you look at the stomach first. In a liver biopsy, is there a method? Is there? How do you go about it? What are the 1 or 2 methods?
Say liver biopsy, first you see under low power, we scan the entire slide. Then we begin seeing there is no hard and fast rule. Whether you start from the terminal hepatic venule end or you start from the portal end. So Usually, because most of the time this is done for hepatitis, many start from the portal tract end and go to the terminal hepatic vein. Others, for example, if there is, it's a butt Chiari or most of the changes are from the central area, you can start from the central and then go gradually. But first on the lower part, you see the entire architecture. If you, whether there are nodules, whether there is any inflammation, particularly in certain portal tracts, like in HCV, it will be there. Then you take your focus to that side and then you start from that end. See if there is any cholestasis. If it's repeating in all the centrizonal area, then there's some problem in the distal bile ducts. You're seeing cholestasis everywhere and so on. So that's how it's done.
Thank you. A lot of questions are coming in the chat
Yeah.
box. I think we'll do a few of them and
Yeah,
then we'll
sure.
come back to your talk.
Yeah.
So the first question is from Dr. Deepak Kumar. How does reticulin and meson trichrome are different in staining for collagen?
Yeah. See, the type of collagen that is stained by reticulin is different from the type. There are different types of collagen. Collagen 1, 2, 3, 4, 5, 6, and so on. Now, the reticulin stains a specific type of collagen that is found especially in the basement membrane, lining vessels, lining capillaries, and so on. So that's where it is there. And because it's closely associated with the hepatocytes, it helps us in giving subtle changes in the architecture. The mesons trichrome stains the other collagen. They are generally not found in the sinusoids. Normally, the liver, as I told, the sinusoid is fenestrated. It's not fully thick or this one, others, it doesn't allow exchange. You will not find all the collagen with the mesons trichrome stains located there. They are mainly in the portal tract. From the portal tract, if there is fibrosis going here, there, or for example, around the terminal hepatic venule, if the collagen very little, just around the vein, on thin line. On the other hand, in alcoholic liver disease or in butt Chiari, you'll find a lot of these collagen laid there. So that's how it helps.
Okay.
That's why we do both. Yeah.
Thank you. The next question is how to identify the zones. I guess is zone a more theoretical concept or does it use it in practice?
Yeah, there is no line that this is this zone and that is. It's not like the G junction Z zone or where you can. There are two different. It is an approximate thing, like
Okay.
your like in the stomach. If you want to divide into 3 areas, 1/3, 1/3, 1/3. So it's
Okay.
something like that.
Okay. Okay. Dr. Priyanka Kumari has asked, why not rely on Rappaport system rather than the Kiernan system? Any reasons when?
Yeah. In fact, most of the biopsies now will tell you about zone 3, zone 1, zone 2. Textbooks talk about zone 1, zone 2, and zone 3 more than the usual periportal, centrizonal, or midzonal areas. You are right. That's what is being followed in most places now. It's gone there.
Okay. Here's a question. Why not do only HNE and collagen? Why do PASD for all patients and keep only for storage disorders?
Yeah, PASD helps. See, we do for hepatitis. No, PASD also stains lipofuscin. So therefore, if the lipofuscin is normally found near the centrizonal area, it's a normal wear and tear pigment, and in some of the hepatocytes. So when the hepatocytes undergo necrosis and they are now regenerative, the lipofuscin that was there in the hepatocyte is taken up by the Kupffer cells. And from the Kupffer cells and macrophages, it goes into the portal tract. So if you find this diastase pass positive material in the Kupffer cells and in the portal tract, there has been a recent episode of hepatocyte necrosis, which you may not see otherwise. The other thing is, especially it's not required now. It was traditionally, in UK and all, they used to always try to screen for alpha-1 antitrypsin deficiency as one of the causes for chronic hepatitis. They didn't have that much of it. So they used to do, and this is one easy way of detecting this.
May I just ask you, sir, in your vast experience, have you come across alpha-1 antitrypsin in the liver in Delhi, or it's uncommon?
You know, it's very uncommon once in a way, and especially because it's a tertiary care institute, no, the pediatricians used to get, but on the run that we have diagnosed and somebody has not thought of it earlier, I don't recall.
I think the same was the experience here. I remember Dr. Bhanumati Ramakrishna making the same comment that alpha-1 antitrypsin, like you said, is more of a UK or a European problem rather than what we find in India. Here's a question from Dr. Jayanti, especially in non-cirrhotic portal hypertension, like NCPF, NCIPH. In transjugular liver biopsy, can one reach the porta?
Porta. You see, in transjugular liver biopsies, actually, even when earlier institution people are doing, they were not very good. Now, the biopsies that we get are fairly good. I mean, through experience and other things, they're fairly good. And we do get a lot of portal tracks. But naturally, in a core biopsy, you tend to get better biopsies than this.
Thank you, sir. Dr. Manmohan has asked, in patchy liver disease, how can we increase the yield of liver biopsy?
Yeah, see, in chronic hepatitis, especially hepatitis C, it's a matter of chance that how you yield. Nobody has found a way, even by doing fibroscan or anything, that this area and that you can't just make out. It's a matter of chance, and usually people, that's why that minimum of 2 centimeters or 3 centimeters, and the more number of passes up to 2 or 3, the yield is more. I'll show you what people have found.
I think I'll take on only 2 more comments because it's time that you should come on. Otherwise, the comments will be.
Sure.
So here, what book is good for beginners in GI and liver path?
See, there's a small book which is relatively good. One that is by Peter Shire. That is a smaller book. The bigger book is, of course, Maxine. So there's Maxine. There's one by Sanjay Kakkar. That's also good. So you can take Peter Shire's book, that's relatively smaller book than others. And actually, you know, Sheila Sherlock's, Dame Sheila Sherlock's hepatology book gives a fair lot of pathology in it in each and every chapter. Best is, you know, sit with your pathologist across the microscope, and if you are free, actually residents are very busy, you know, but if they can find time sometime and sit and discuss the cases that they have done biopsy, it will be helpful.
Lastly, there's a comment from Dr. Matthew Phillip. There's a new technique of EUS, endoscopic ultrasound guided liver biopsy, which is also becoming popular in India. Any comments on this regarding tissue yield?
I'll say we have very little experience. So EUS liver biopsies are becoming, I'm sure it will increase more and more. I think Dr. Philip's center may be doing more, but here our center we are doing less. So our experience is very little. At least my personal experience would be very little.
Okay. Thank you, sir. I think we've given you enough time to catch your breath. Not really. You've been working hard on here as well. Maybe we can come back to your talk and then take on more questions later.
Okay. Right. Thank you. So now I see we'll just go into hepatitis. You see this, why I put this up was, now hepatitis is divided into acute and chronic with the 6 months. So who found out the 6 months gap? What is the big deal in 6 months? The reason why it is 6 months is, you know, in 1960s, there's been a good paper in Lancet in that 64 or 66, I think that time. But anyway, in 1960s and 50s and 60s, they used to do a lot of liver biopsies in acute hepatitis and chronic hepatitis. general consensus after a lot of studies was that the changes of acute hepatitis disappear in 6 months' time. And therefore, this arbitrary distinction was made that acute hepatitis is less than 6 months, chronic hepatitis is more than 6 months. As the period goes, it's realized that, of course, chronic hepatitis can present clinically for the first time below 6 months, and acute hepatitis, of course, very rarely, although there have been case reports of hepatitis E also going on for more than 180 days. But so this is how it's mainly histological. By and large, you don't do a liver biopsy for acute hepatitis. Acute viral hepatitis is generally not required at all. So maybe in acute drug-induced or some other cases, you may do. So the indication is absolutely gone here. You may do for subacute, right? And of course, for chronic cirrhosis, hepatocellular carcinoma, this part. So most of the biopsies deal with, I think, this part of the chain here. Okay. Now the chronic hepatitis, the earlier understanding was persistent if the inflammation was in the portal tract, lobular if the inflammation was in the lobular, and aggressive if there is a piecemeal necrosis. This was worse, and of course, these had much better prognosis. But these are considered separate diseases. Chronic septal was another one that's added. Okay. Now, the knowledge regarding chronic hepatitis at that time was scarce. Now we know there's autoimmune hepatitis B. Non-A, non-B was then found, and then we now know that this is hepatitis C giving chronic liver disease. And of course, we have this classification. Now, supposing now we have very good non-invasive tests, molecular biology and other markers to distinguish different types of viral hepatitis, your DNA levels and other things which will guide you to your management. You do not require a diagnosis by a liver biopsy per se to make it whether it's hepatitis B or C, so on and so forth. You require for grading and staging. There's a lot of controversy regarding staging with fibroscan and so on and so forth. Now let's take this history. So clinical hepatitis, what is the etiology? If it is less than 6 months, whether it's acute or resolving, whether there's exacerbation, whether there's fatty change and so on and so forth, we find in every biopsy. Now, in all hepatitis, acute or chronic, there's hepatocellular damage. If the damage to hepatocytes is sublethal, you get ballooning or fatty change. The liver cells can come back to normal. If there is cell death, then it could be because of apoptosis. Most of the liver diseases we deal with are viral, and viral infections cause cell death majority by apoptosis, or then it can cause necrosis. If the necrosis affects 1 or 2 cells, it is called spotty or focal. If it affects a lot of cells, a group of cells, 3, 4, 5, 6 or more, then you call it confluent necrosis. Now, if the confluent necrosis is between 2 vascular trees, terminal, or shall we take from the central area to the portal area, or from central to central, or portal to portal, then it is called bridging necrosis. If it bridges 2 vascular compartments, which are well defined, it is called bridging necrosis. If it affects the entire lobule or acini, then it is called panlobular or panacini. Now it affects just between the portal tract and the parenchyma. It nibbles into the limiting plate or the interface between the portal and the parenchyma. Then it is called piecemeal necrosis or interface hepatitis. So confluent necrosis could be either confluent, you just within the lobule. If few hepatocytes. Or if it is between two vascular trees, it's called bridging necrosis. If it is so confluent that it affects the entire lobule, panlobular or panacinar. And if it is at the interface between the portal tract and the hepatocytes affecting the limiting plate, then it is called interface hepatitis. Naturally, this type of bridging necrosis is worse from terminal hepatic venule to portal tract because it causes an intrahepatic portal portosystemic shunt. That's worse rather than central like you see in Budd-Chiari veno-occlusive disease. Okay, right? So this is the different. Let us go. This is ballooning degeneration. In ballooning degeneration, the sodium potassium pump is affected like in most injuries, So there's a lot of fluid inside, becomes large, the sinusoids get compressed. And in fact, lot of ballooning degeneration can compress the canaliculi and cause some amount of canalicular cholestasis and account for some amount of the jaundice that you get in acute hepatitis. Now, in some cases, the ballooning, the size does not increase in size, and there's wisps of cytoplasm here, what people call as feathery degeneration. Now, very difficult to distinguish between ballooning and feathery. As the only change that people say is feathery, the cells are not as enlarged as in ballooning. And in feathery, you may get some bilirubinostasis within the cells. And that's why feathery degeneration is almost restricted to biliary obstruction. But anyway, there's no marks if you cannot distinguish between the two. Now, in children and in others, you not only get ballooning degeneration as a form of regenerating change, you often get more than three or more nuclei within the same cell. So when you get a large cell with 3 or more nuclei, you call that giant cell. And this is typical in neonates, and it's called a giant cell hepatitis. See, more than 3 nuclei here, they are large cells, and this is called neonatal hepatitis, where you get giant cell. So giant cell will have 3. Now, if the cell is not enlarged to that extent, and it is almost like this, you don't call it ballooning change. If it is rarefied like this, it could be feathery because of obstruction, or when it is absolutely clear with these well distinct cell borders, and then you have to do a pass and pass with diastase, because this is typical of glycogen storage disease type 1. You can get these cells full of glycogen. They also look like that, except in ballooning change, they will be big. Here, they are not big. These large spaces are because of fatty change. Now, here, these cells are enlarged. They are not water clear. You find a small little rounded nodules. So this is foamy degeneration. Foamy degeneration is generally associated with accumulation of fat within the cells. This can be seen in NASH. It can be seen in glycogen storage disease. It can be seen in alcoholic liver disease and various others. The important thing is this foaminess is so fine that often you cannot see it. You have to do a lipid stain. So these are the different. So a cell can be large, mainly because of hydropic change. When it's a ballooning degeneration, it can be clear in colate stasis. It can be clear in glycogen storage disease. It can be clear when there is fat in the cells. Now let's come to the necrosis we are talking about. This is spotty necrosis. In spotty necrosis, sometimes you just don't find hepatocytes, you just find lymphocytes there. So that itself is spotty necrosis. And in liver, because most of them are viral infections that we are dealing with when we do liver biopsies, you hardly get neutrophils. So although it may be an acute hepatitis, in viral infection, the cells that go there to um, save us from viral infection are lymphocytes and NK cells. So, and that is why you will find mononuclear cells here rather than polymorphonuclear cells. And here in spotty necrosis, single cells get destroyed and you will find lymphocytes. Confluent necrosis, this is a group of 4 or 5 hepatocytes. They should have been there, they are not there. You are finding inflammatory cells. This is confluent necrosis. This is piecemeal necrosis. When the boundary between the parenchyma and the portal tract is lost, these to the limiting plate and going inside. This is piecemeal or interphase hepatitis. Now this is bridging necrosis between one portion and the other. In almost all cases of subacute hepatic failure, you will find bridging necrosis. And this is panlobular necrosis. This is one portal tract. This is another. So you see this the entire lobules have necrosed. We'll see other examples, and therefore the liver would be shrunken in size. The liver span will decrease. You do an ultrasound, it will be a very small liver. These are the cases that present with acute liver failure, fulminant liver failure. Even severe bridging necrosis can do that. Okay, so severe necrosis. Look at this. So this is another form of panlobular necrosis. One portal tract, 2, 3, 4. You'll hardly ever get in a liver biopsy like this. So this panlobular necrosis. Now you see in these cases, the reticulin as well as mesenteric are unhelpful. And in fact, in a case of bridging necrosis, like if you call this bridging in this area, panlobular in this area, you can get a combination. If you see the bridging necrosis in this area, if you do a mesenteric, it gives you a mistaken form that this might be cirrhosis. And in fact, in subacute hepatic failure, you get a spleen that is palpable, some little ascites, pedal edema, and a liver that is a little small, although it may not look nodular, it may look nodular in some ultrasound. And if you do a liver biopsy with mesenteric, it's not actually the deep blue color of this. You may mistake it for cirrhosis. So these stains are not that helpful. On the other hand, if you do an Orsin stain in cirrhosis, you will find this definite nodules of Orsin here because they are elastic fibers that are generally restricted around blood vessels in the portal tract normally. Whereas in bridging necrosis, so this is cirrhosis. Whereas in bridging necrosis, the Orsin stain will be confined to the portal tract. It will not stain the necrotic area. In fact, Shikata was staining these necrotic areas when he by chance discovered that they also stain hepatitis B surface antigen. So this is a good stain to distinguish bridging necrosis from okay. Now this is how an apoptotic cell looks like. It looks like somebody has put in a syringe and pulled out whatever there was there. So this cell drops out from the scaffolding of reticulin. The architecture is still maintained and the adjacent liver cells and the cells regenerate to fill up this gap. This is another apoptotic cell. So this is a form of single cell necrosis, spotty necrosis, or focal necrosis. Okay. Now this is an area of confluent necrosis. 1, 2, 3. You should have seen 2 or 3 hepatocytes here. On the other hand, you are finding a group of hepatocytes that are missing and there is inflammatory cells here. This is confluent necrosis, which is not qualified. Confluent necrosis. This is another area of confluent necrosis in the centrizonal area around terminal hepatic venues. These hepatocytes are lost. So this is unqualified. This would be bridging necrosis, you see, extensive with panlobular necrosis also. See here, portal to portal, they're so near. Naturally, the liver span will be decreased in this case, and there will be severe, is almost like fulminant hepatitis. This is a good example of bridging necrosis. That was panlobular bridging necrosis. See, from one area to another. From far, it looks almost like cirrhosis, but it is not. These are necrotic areas. Okay, this is the reticulin stain. This is the mesons. This is once again to show you that the elastic tissue will be absent there and the orcine stain will be negative. This, you see, this is the interface. You can't find the limiting plate. These little lymphocytes and other mononuclear cells are nibbling into it and going into the lobule. This is interface hepatitis or piecemeal necrosis, what was called piecemeal necrosis. These cells are ringing around hepatocytes. This is called peripolesis around hepatocytes. This can be seen in several diseases, right? Right. And you see this, this is at the border, all these lymphocytes, plasma cells going into this. This is a plasma cell, eccentric nuclei with a lightly pale colored off region here. They're going into this, right? So this is interface hepatitis. See here, very nicely. This is slight ballooning of these cells here. Yeah, and this is the bile duct. This will be the portal vein, and they are all going here. You can't, margin is blurred, and we see how much of the circumference is affected. This is more than 50% of the circumference that's affected by piecemeal necrosis. See, piecemeal necrosis is almost like water overflowing there. See this? Fairly severe here. And this is what was telling in patchy disease. So this is so severe here. This portal tract, the piecemeal necrosis is mild. So, and here also mild. If your needle went through this area, naturally you would have undergraded this. And if you go through this area, then naturally you would say that this was much more severe piecemeal necrosis here, right? So this is an eosinophil here. So the earlier grading of how much of inflammation was there. So you can get inflammation or these inflammatory cells confined to the portal tract. It can go and cause interface hepatitis or piecemeal necrosis, or you can find inflammatory cells within the lobule. Either single cells will get necrose, spotty necrosis, or groups of cells when it is confluent necrosis. So an attempt was made how to grade. Can we grade it as less or more inflammation so that we can compare the same person's biopsies as the disease progresses rather than two people, because there's so much of sampling variability. Can we also tell is because the end result of inflammation is healing and repair. And in the liver, healing and repair results in fibrosis. And if the fibrosis is extensive, it will result in cirrhosis. So inflammation, healing and repair resulting in fibrosis, and the fibrosis going on to cirrhosis. Can we grade, can we tell how this is going on? First attempt was made by Nodell et al. But the problem with Nodell's thing is that there are two problems. One is from 1, it jumps to 3 and 4. Sometimes there's a missing number of 2, right? The second was that, say 1, there's no 2, 3, 4. 1, no 2, 3, and 4. So that was one problem. The second problem with Nodell's is that he combined fibrosis, right, with inflammation. So that was the problem in that. So he combined, say, fibrosis and inflammation together, and then you add up all these scores, the fibrosis score and inflammation score, and then you arrive at a histological activity index. But one must appreciate this was the first attempt to ever think in this manner. Secondly, it was done decades ago. At that time, our understanding of both hepatitis and the diseases, we knew about non-A, non-B. Hepatitis C was not there. Non-A, non-B, we knew what it was not. We never knew what it was. So it was that state of affairs. We knew about hepatitis B. So given all that, this was a landmark improvement in hepatology as well as hepatic histopathology. This was the first paper and it opened the eyes to the world that this can be done. So then later on, when we realized that fibrosis and inflammation are two separate things, although one leads to another, everybody sat together and thought that in malignancy, we grade the malignancy as well as we stage the malignancy. Staging is how far the malignancy has spread, and grading is how much the cells resemble the original or differentiation. So the same thing was applied here by pathology. So grading is how much of inflammation is there, and staging is how much the fibrosis has progressed to cirrhosis. And these are two independent factors. So you have the international liver group, periportal, confluent necrosis, focal or spotty necrosis, and portal inflammation. And if you notice, confluent necrosis includes bridging and pan-acinar necrosis, which I told you. And of course, periportal is mild, moderate, or severe, depending on less than 50% of tracts or more than 50%, and so on and so forth. Portal inflammation, mild to mild. So this is what is done. The French cooperative group did this for their study on HCV, specifically for HCV. This is the Metavir classification, which they did. Okay. And there are several other Shires grading system, Ludwig Bats. Basically, it's similar thing. How much of portal inflammation is there? How much of interface? How much of lobular inflammation and necrosis there? And fibrosis, how much? There is fibrosis stage of 6 in the previous one, which I showed you, and many thought that a 4 would be a much easier and better one. So it depends what you do. So this is mild activity, severe activity. So similar thing you get to see. Okay. This is no activity.
Yeah.
This is minimal activity, moderate, severe. There is some shaking of this. I don't know why. Okay. So these are the things. I don't know why it is shaking a bit.
Dr. Dattagupta, can I just, yeah. I think we are, a time factor is coming in. I think a lot of questions took up time.
Okay.
So maybe another 10 minutes to
cover
10 minutes,
what you
we'll
would. Finish. We'll finish. Okay. So this is what is done. No fibrosis to cirrhosis. This is the inflammation. So histological would be grade 3, stage 6. This may not mean much as a clinician. So please insist on the pathology writing. It is cirrhosis with mild inflammatory activity. It will help the clinician. It will also tell the clinician how to explain to the patient, right? So please remember, all these changes can be seen in drug-induced autoimmune, other viruses, and so on. But in drug-induced, generally the necrosis is very punched out and clearly marked. There are other things. This is a cholestatic rosette, cells surrounding a rosette, like cells surrounding canalicular rosette, sorry, with bile here. This is a cholestatic rosette, no canaliculus in the middle. Why I brought in the term cholestatic rosette is because these cholestatic rosettes are very commonly seen in autoimmune hepatitis. Okay, this interface hepatitis and other things that you see. Remember, in acute hepatitis, the changes are diffuse. It affects all the lobules almost equally, centrizonal more than periportal. But in this is zone 3 more than zone 1. But in chronic, it is always patchy, and the portal areas are affected more than the centrism. So this is how you affect this. Do you get fibrosis in acute hepatitis? No. Exception is cholestatic fibrosing hepatitis, which is seen in immunocompromised individuals, post-transplant HIV, so on. This is acute hepatitis with lot of fibrosis. Okay, fibrosing cholestatic hepatitis on this. Okay. Can you identify the etiology? Yes, hepatitis B definitely. Hepatitis C if there's fatty change, portal lymphoid aggregate, and so on. Okay, so this will be hepatitis C. You can get fatty change. We see in about 25% of our cases. Hepatitis B, this is ground glass hepatocyte. Okay, you can do immunohistochemistry, Orsin stain, and so on. The only thing that looks like this is after cyanamide therapy or Lafora bodies. You can do surface antigen, core antigen, and so on. Now, for example, this is a thalassemic with abnormal liver function test, HBS negative, HCB positive. Now, do you need to do a liver biopsy to make a diagnosis? Not at all. You don't require. But why do you require a liver biopsy? Liver biopsy tells you the grading and staging, and also how much of hemosiderin is there. See, this is hemosiderin pigment, right, in the cells, and here this is the Pearl's Prussian blue, hemosiderin in the portal tract, in the lobule, right? These are in the along the sinusoidal border of hepatocytes. These are in the Kupffer cells, right? How much of fibrosis is there by the reticulin stain Masson striking. So the biopsy will tell you it's mild to moderate activity with fibrosis. Histological grade is 5, moderate. Histological stage is 3, maximum 6. Hemosiderin grade is 3. So it helps you. You give desferrexamine therapy or whatever, and then you repeat the biopsy. Repeat biopsy helps in the same individual. In NASH, same thing, just like that. First you have fatty change, then the fat, then you have the steatohepatitis, and then cirrhosis or fibrosis. So this is the same thing, except that fat helps. The other thing in NASH which I want to tell you is you have microvesicular steatosis, which is generally just like foamy hepatocytes. You have to do this, right? These are varying grades of fatty change. Portal inflammation is less. These are the fatty change which I showed you. Sometimes you can get small cysts by all these joining together. You can get oleogranulomas, small granulomas around fat. Okay, you see this, very little inflammation. You can get Mallory's hyaline, although this hyaline is nothing as extensive as in alcoholic liver disease. In alcoholic liver disease, you get more extensive. And in alcoholic, you get a lot of neutrophilic infiltration. You can get some portal inflammation. These are glycogenated nuclei, which looks absolutely blank. You can get it in Wilson's disease. You can get it in diabetics. You can get it in NASH, right? These are mega mitochondria. They're not alpha-1 antitrypsin bodies, large mitochondria, right? And the fibrosis is pericellular or chicken wire around individual cells. Okay, this pericellular fibrosis around individual cells, which you get in NASH. This is another example. And then, of course, you can get cirrhosis. So in pediatric, it can resemble the adult, or it can have a separate connotation, right? Okay, type 1 is less common, zone 3 fatty change, common in adults, and it resembles common in girls, resembles adults. This is more common in boys, where there is zone 1 fatty change, fibrosis is portal. You can get this. In NASH also, you grade steatosis, ballooning, inflammation. State Bank of India, steatosis, ballooning, and inflammation. And you do it grade 1, grade 2, grade 3. Similar thing, what you do, is it less than 5%, 5 to 30. 5% is the cutoff, because in ultrasound, the minimum that you can find out is 5%. Okay, that's what it's less than 5% is normal. So this is how you grade steatosis, and then you grade the fibrosis also, how much there is. Okay, this is similar to what you do. These grading staging systems are similar. But please remember, you cannot diagnose NASH based on grading and staging, just as you cannot diagnose hepatitis. The histological diagnosis should come first, and then the grading and staging. So this study clearly shows by Brunt and their group, which is the largest group studying NASH, that if you do a histological diagnosis and you do a grading, often you can, by just grading, you cannot make the histological diagnosis. It's very important to realize that. Okay. So this is a case of a non-alcoholic. The steatosis, inflammation, ballooning, Mallory-Denk bodies, and reticulin stain tells you. So micronodular cirrhosis, you grade, you stage this. Please remember, this is a study which shows that the disease activity is underestimated if the biopsy is thin and if the biopsy is not long. Okay, so there's a clear study by this group which appeared in Hepatology. And like, for example, if you take from the left and the right lobe also, there is a difference in the grade and stage, almost in 1/3 to 1/4 of cases, as high as that. It may be lower also. So therefore, in patchy disease, this will always be a problem. You may always curse your histopathologist that it's not correlating clinically, or vice versa. So this will always be there. Please remember, cirrhosis is not the end stage. Now it is known that if you have thin fibers with large nodules, okay, so it is better. So thin fibers has a better prognosis, thick fibers has worse prognosis, small nodules carry a worse prognosis than larger nodules. Okay, and cirrhosis can be subclassified into 4A, 4B, 4C, depending on the nodule size. And this has been correlated with your hepatic venous portal gradient. If you use 10 as the cutoff, no, depending on the nodule size. Is the larger nodule and smaller nodule, look at this, okay, and septal thickness. There's a very good correlation between thin and small nodules, large nodules and thick. So that can be included in the diagnosis. Okay, so progressive, and if the septa are not complete, it's predominantly regressive. So this, there is a Beijing classification related to this. You can read about it. So this person is likely to do better. This cirrhotic is likely to do better than him or her. So there's a grading of cirrhosis that is there nowadays. There is another grading that is done. This is the for rejection. And please remember, in rejection, what I wanted to show you, not only you have portal inflammation, you have what is called endotheliitis. These inflammatory cells literally peel off the endothelium. And this could be in the centrizonal area or in the periportal venues. You also get eosinophils, right, in acute cellular rejection. Look, a lot of endotheliitis. You can get cholestasis. Look at this endotheliitis. So this was mainly to show you what you get in acute rejection. You can get ballooning, you can get cholestasis, which is same. And in chronic rejection, of course, you can get paucity of bile ducts and foamy histiocytes, and because basically there's loss of bile ducts, it looks like obstruction and so on. So this last case, you'll find raised gamma glutamyl transaminase. This got itching, cholestasis, and you're finding a granuloma, right? So this is a PBC because this is biliary centric. You can get a granuloma in tuberculosis also, in sarcoidosis also, right? So the clinical finding is very important. Another obstructive jaundice, you're finding the bile duct there, but if you keep searching, there's some loss here and cholestasis. And if you see here, there is this onion skinning. So you can say it is suggest, and there is this orcine with these brown things, which are copper binding protein consistent with primary sclerosis cholangitis. This is a hepatocellular carcinoma, no mark. So you also do biopsy sometimes for malignancy. This turned out to be hepatocellular carcinoma or an adenocarcinoma. Now, this is an important slide. You know, this was study done in 93, but it's true even today. Supposing you take a biopsy, you have a report, and then you sit with your pathology. You have a conference, clinical pathological conference, and these are breast, dermatology, ENT, oral, general surgery, oncology. The maximum changes in the diagnosis happened with gastroenterology. So it clearly shows there are so many areas. Even in oncology, there are some, but in oncology, you now have a lot of immunohistochemistry, others. They tell you what tumor it is to a large extent, a lot of molecules. In gastroenterology, there's so much of clinical pathological correlation to be done, whether it's hepatology or luminal, it's absolutely mind-boggling. There is no doubt. In fact, the printed paper that goes to you as a report may be the quarterfinal or semi-final. You have to sit with it. You have to sit with your pathologist. The pathologist has to sit with the clinician. You just cannot exchange. One sends a requisition form, another sends a report. It's better we do away with all that as far as GI pathology goes. This is true even today. There are studies to show that, but this was quite dramatic. That's why I wanted to show you. So thank you very much. Sorry for having taken time. I haven't covered everything. I just went through most of it. Thank you, Dr. Epan. I'm sorry for exceeding the time.
Thank you, sir. Thank you for an excellent presentation. It's a very vast area and it's difficult to know what to talk on, which topics to pick up. I can understand your dilemma, but really enjoyed what you taught and shared your vast experience. I would ask Govind what to do because I know that we have run over time. So I'll hand back to Govind to ask for his comments.
I want to discuss some questions, or we take a poll questions. Can we take some poll? Because can you stop sharing your screen? Sir?
Yeah.
So we have some poll questions which just show us. Can you launch the poll, Prasant?
Yes, sir. Yes, sir.
So we'll have some poll questions. I think you respond. All of you should respond. What do you like these poll questions? Yes. So just respond to this question, please. I think it's going fantastic. Datta Gupta, you have impressed them. So I think everybody is right in that case. The message went very well. So you're able to see the results, sir, no?
Yeah, wonderful.
Yeah.
Okay, good.
Right.
Very good.
Second question. Yeah. Question 2. Yes.
Excellent. 100%.
So are you happy with
Yeah, very good. You know, the answer is bridging necrosis, which most of you told. It is between one vascular tree, that is the hepatic vein, and the portal tract. So it bridges two vascular. So bridging necrosis, those who have said, very good. Panlobular is the entire portion going on. Okay. And then piecemeal necrosis is at the interface between the portal tract and the hepatic lobule.
the next question, please?
In this, no, the still going on. The answer is Orsin stain, because you see the Orsin fibers are located only in the portal tract, and when the reticulin is present both in the lobule and when there is necrosis, the reticulin framework collapses, and because it collapses, no, it looks almost like fibrosis. So reticulin stain is not good. So the Orsin stain, which will not be there in the lobule, if there is cirrhosis, it will go in like this when there's fibrosis. If there is necrosis, it will be negative. So Orsin stain is the stain that is used in this.
That's a tough question, sir.
That's a tough question, I know. That's a tough question.
Last poll,
One.
please. Last question, last poll. Yeah.
So this depends on, is it American or European?
I think everybody is European, most of them are.
I mean, ASLD says 30 millimeters, what you said.
Yeah. They said 20. More the merrier, but at least 20 it should be. And
Okay.
you're up to 3 passes. Yeah. Very good. Any more? I think there's one more.
One more, maybe one more. Prashant, one more, last one. Yes.
Good.
Dr. Gupta, sir.
Yeah, bile is the best answer in this. You may see occasionally, very rarely plasma cells. Lipofish can normally see reticulin fibers. Good, good, good. You know, they're going to put me out of business. They have not, they have done very well. No, actually, most of them are DM students. All of them are bright boys and girls. So. And it's very heartening that they have been able to, tolerate so much of pathology for quite some time. And so it's very heartening. Thank you, Govind.
Sir, thank you so very much. I think it was a so engaging lecture, starting from the need for biopsy indications and what are the options available, what are the complications. I'm talking about each aspect of liver inflammation. What is P-small, what is the interface, what is spot necrosis, what are the stains we do, and how do we stage and grade of disease, both for hepatitis and also for fatty liver disease. It have been really remarkable. Your slides, your depiction of the line diagrams have been fantastic. I mean, so difficult for all of us to understand the liver pathology, because we're not tuned to see these. I mean, we have different picture in mind.
Yeah.
I think you added value to that that learning process. And think we are getting that some feel of it, that how lobby looks like, what will be single cell necrosis, what will be confluent necrosis, what will be pan-level necrosis. So I think these keywords, I hope, is very valuable to all our participants, and this it have been remarkable, and I would say typical masterclass by you, sir.
No,
And
thank you.
again, thank you so very much for your very elaborated discussion on this topic. We are sorry that we asked you to stop in between, and we
No,
made
not
fast
at all.
forward.
Not at
We went
all.
fast forward in last moment, but since this is a
No.
we crossed some times, therefore the apology for that, sir.
Not at all. Not at all. In fact, I'm honored that Dr. Eapen was there and you're there, Dr. Goenka is there. And yeah, you had a crowd of wonderful students, I'm sure. And
Not only that,
I'm really grateful to all of you for,
and we have also
getting bombarded with.
very senior people in the audience also, not only students or
Okay.
trainees, but there are many senior people. Dr. Jayanti, I can see a number of them
Okay.
are in the audience. So it's like a Pan-GI
I'm honored.
or the
I'm really
conference.
honored.
Dr. Eapen, thank you so very much again. You always are so elegant.
Thank you, Dr.
Add value to our master classes.
He's always.
Thank you so very much, everyone, for joining in. That's on Sunday, and that's also is very precious to us that you joined for the master classes. And we strongly believe this is a good way to educate or share our knowledge with each other, staying distant, but again, still we remain connected with each other through these master classes. Thank you so very much, everyone.
And Govind, I think this online thing has helped gather so many people from all over everywhere to join these classes. Except that, of course, they'll miss the lunch, which ISG provides so lavishly always. Anyway, thank you so much. Thank you.
Thank you so much, sir. I mean, and lastly, we will have a next masterclass so we'll have a masterclass every other Sunday. So we'll skip next Sunday and we'll have a next masterclass on 29th of May. And again, this is a important topic. And how do you interpret small intestinal biopsies, celiac disease, tropical screw, Crohn's disease, and so many other diseases we'll discuss. And this masterclass will be done by a very dear colleague, and I think is again one of the students of Dr. Datta Gupta. There's a Prasanjit Das, and he's very elegant and very thorough, very meticulous. So we'll have a next masterclass on interpretation of small intestinal biopsies on 29th of May, 2 weeks from today. Till then, thank you so very much, and do join in for the next masterclass, and have a great day ahead.
Thank you, Dr.
Prashant. Thank you, Prashant, and thank you, Nisa, for organizing this for us. And thank you so very much, everyone.
Thank you. Bye-bye.
Bye.
Thank you, sir.
Thank you, Dr. Eapen. Thank you, Dr.
Thank you, sir.
Thank you, Dr. Goenka.
Bye-bye.
Thank you, Dr.
Thank you, sir. Bye.
Bye.
Thank you, Prashant.